if you want to record it.
Good afternoon, everyone. For the first of our 3 webinars that the Joint Work and Health Directorate for DHSC and the DWP is undertaking in partnership with the Society of Occupational Medicine on the incredibly important topic of work and health. We're going to have a real focus on how we support services at place to deliver the good health benefits that come from good work, both for individuals, employers, and our wider economic and population health here in the UK. I'm delighted to have Lan Ray, who's the chair of the Society of Occupational Medicine, here, and we'll be doing a little bit of a double act later on. And you've got 3 absolutely fantastic expert speakers who'll be taking you through our 3 substantive items today. We've got Dr. Steve Borman, chair of the Council for Work and Health, who'll be focusing on models of occupational health and the value of low-intensity biopsychosocial interventions. We've got Karen Orman, who's the Royal College of Occupational Therapy Director of Practice and Innovation, focused on the role of occupational therapy and vocational rehabilitation. And we've got Janet O'Neill from the National School of Occupational Health, talking about the different roles in a multidisciplinary team and building capability. This agenda is incredibly important. And so I just want to start as chair, just taking a few moments to talk about why this is important. And for any of you who don't already know me, my name is Jean King, and I am Deputy Director for the Health Division in the joint DHSC DWP Work and Health Directorate. And over my 3.5 years working in this space, I've had the privilege of leading on occupational health reform, leading on fit notes, which is now grown so much. It is with another colleague, working with work and health systems on the work and health agenda, including the Work Well Partnership Programme, which again has grown massively, and you'll be meeting Alex Fitzpatrick in the further 2 sessions that we've got on this, and she'll be chairing those, as well as looking at work and health workforce and musculoskeletal conditions across the life course, where again we've had sizable investment in how we support people with that major condition with their employment and also physical activity outcomes. So in a nutshell, the Joint Work and Health Directorate came together in 2015 from the 2 departments to reflect the shared agenda and significant link between good work and its contribution to good health outcomes. We know, unfortunately, that long-term sickness continues to be the most common reason for economic inactivity among the working population, and the figures at the moment have unfortunately continued to rise, with 2.5 million people, sadly, who are economically inactive where a health condition is given as one of their main reasons. The leading cause is mental health. The second is musculoskeletal conditions and largely chronic pain. The third is cardiovascular disease. We also need to acknowledge that there are many unpaid carers who are also out of the labour market due to needing to support those individuals as well as people who may have retired early but may have an underlying health factor as a reason that they've chosen to step away, and they might be able to return with the right support. That's why the government is really committed to making sure that all people with health conditions and disabilities can start, stay and succeed in work, and that we get the right access to the right work and health support in the right place at the right time as an absolutely critical component of this. So obviously we can't do this alone. This is very much something that in all of our nationally delivered programmes, we work with local authorities, integrated care systems and others to support this agenda and government's commitment to levelling up and to improving and protecting the nation's health and reducing health disparities. So in order to make this a success, a huge number of programmes and initiatives were both announced by the government in the last few years and also scaled up This includes employment advisors in talking therapies, which has increased from 40% coverage across England to over 100% of coverage. And we're looking to roll out the piloting of that employment advisor model into musculoskeletal pathways later this year. At spring budget in 2023, £64 million was announced for the WorkWell partnership pilot to support around 60,000 disabled people and people with health conditions to start, stay and succeed in work. And earlier this year, November, a competition was held to invite applications from partnerships for integrated care boards in England to become one of the vanguard organisations, and that process will shortly be sort of announced in terms of the outcome of that. We've also been looking at fit notes. So in 2022, we extended professionals who could certify the notes from beyond just doctors. And you're going to hear a lot more about the importance of a multidisciplinary team from colleagues on the call today. But this was about making sure right place, right time, right conversation with the right expert. And we extended from just doctors to nurses, occupational therapists, physiotherapists, and also pharmacists. We further launched the FitNote guidance products update in October of last year to make it easier to navigate and remove outdated information. But more importantly, the work and health conversation is such a core component of how we support individuals at place to be able to navigate the system to get the support they need. And that is why on Friday that we've just had, and you've seen a link's been put in, we announced a call for evidence to understand how we can be truly transformational about the fit note. And when I say that, yes, it is a piece of paper to an extent, but it's more significant. It's the conversation that can be had with an individual where they may be able to work with the right support. What does that look like? How do we support a shift from 93% signing people who just can't work and do anything to lifting that number, bringing that number down and saying a greater number of people with the right support would be able to undertake something? Because we know when people are in work, it helps with their mental health. It helps, often an employer can provide them with occupational health support. And the further you are away from work, often that can really impact your mental health, may mean you're not going out as much, not moving as much, not interacting as much with your society and with community that you're part of as well. So alongside thinking about how we support people with the conversation, and how we look to work with integrated care systems through the WorkWell pilot to put low intensity biopsychosocial work and health support in. We're also looking at how we make sure we have a workforce to support that. So in July last year, we launched the OH Workforce Expansion Scheme, providing funding for doctors and nurses to undertake OH training. We've had roughly just over 200 people commence some of the courses that we've been funding, and that is with huge thanks to the National School of Occupational Health, who have really driven and led that programme forward. We've launched a small-scale digital pilot in the Northwest on OH financial incentives to try and support, again, smaller businesses to also play their role. And employers are such an important part of place as well. And making sure that work and health conversations with a multidisciplinary team support employers is hugely, hugely important as well. We've been investing in innovation in occupational health, including to try and get models of care to support smaller businesses. And we launched a digital information and guidance service for employers into live testing in 2022, and we're looking to continue to build that content. Lastly, and one of the really significant things that we did a consultation on occupational health working better, which we launched in July, and we put our response out in November, and that included announcing that we would develop an occupational health framework. It would be a voluntary framework, but it's designed to help businesses understand of all shapes and sizes what are those core things that you can do to get some of those benefits. And we hope that combined, that huge range of activity that we're talking about, and that is just a snapshot. I barely had a chance saying about universal support or our IPSPC, some of our other huge place and train support programs. The real key thing is that we know that it needs to be integrated. We know that it needs to be joined up. and we know that it needs to be supported by a multidisciplinary workforce of healthcare professionals, expert work and health professionals, and non-clinicians in a range of settings to have a conversation that sparks and supports someone in the right place at the right time to get the best health and work outcomes that are possible. And in that frame, I'm really excited to move into this first session, which is all about how we can do those key considerations around work and health services and the makeup of the team that you can have as part of that. That is all from me, and I'm delighted to hand over to our first expert speaker, Dr. Steve Borman. Thank you.
Thank you very much indeed, Jean. Can I just check that you can see the screen?
Yeah.
Yeah, good. I'm going to start with two apologies. You should never start talking to an audience that you don't know well with apologies, but I'm going to start with two. The first is that actually my screen is rather small and there's been some technical issues in terms of screen sharing with my setup today. And so I apologise, but actually I think it's more about what I want to say rather than the actual size of the slides or death by PowerPoint. And the second apology is that you'll note from the breathy voice and the slightly shortness of breath that I'm actually one of the people that Jean has just talked about in her introduction, who took early retirement from a full-time career and now works part-time in the workforce because of a health problem. But actually, I've been very fortunate to be able to adjust my work and fit my work around the health problems that I actually have. But it does mean that I'm rather breathy in terms of presentational material. I spent 35 years working in full-time occupational health, in both large corporates and in small corporates. But I very well remember right back at the beginning of my occupational health career, listening to Professor Sir Michael Harrington, who is a very well-known professor of occupational health. And the very first piece of training that he gave to me involved these next two slides. And what he explained was that occupational health is actually not rocket science. It's simply about the relationship between the work that an individual does and the impact that that actually has on their health. And then, as I'll show on the next slide, the reverse of that dynamic, the impact of health on the work that people can do. And for many years, the occupational health community was very much about limiting the harm that work could do. In fact, when the health service was created in 1948, occupational health was not part of the mainstream NHS because it was felt to be largely about industrial medicine, and it was felt to be very much about the harmful negative impacts of nasty things that happened at work could actually have on health. But I think in particularly the last 20 years or so, our thinking and understanding has changed quite significantly. We now realise that actually work can have a very positive effect on health. It can help recovery from health problems, but certainly being work less is actually a lot more harmful than being in work, and actually it's more about getting a good fit between work and health in terms of what somebody can do. We also now know that actually returning to work can actually be part of the therapeutic journey. It can actually improve the rate of recovery. It can reduce the extent of disability, I'm not saying return to dangerous work is a good thing, and there may be some limitations on the work that people can do if they have a health problem or a disability. But if you get the fit right, then that work can be health promoting and important. I think it's also important to understand that actually occupational health it is a multi-layered concept. It isn't just about the doctors and nurses at the centre of this onion model. It's very much about a multi-level, layered concept. At the heart of occupational health is the legal requirements that are placed upon employers and employees in terms of them the impact that their health may have on things like health and safety, things like equality, particularly around disability, but also about some of the other protected characteristics, and also about the employment law relationship that people have with their employers. And those are right at the heart of an onion, if you like, a multi-layered occupational health service. As you move out in the onion, you start to get to things that are actually around organisational performance, and very much the stuff that the Prime Minister was talking about on Friday, about the impact on productivity, the impact on performance of businesses, and the ability of businesses to survive and continue in a competitive environment. But we also increasingly are recognising that actually around the outside of the onion are two more very important levels. Part of the next layer out is really about the psychological contract that people have with their employers. And we know that actually if you feel engaged, if you feel cared for, if you feel your employer is supportive to you, then people are much more likely to go the extra mile, provide better services, provide better quality, and also, as I've said earlier on, contribute to the productivity. But we also increasingly realise that actually it's not just in work, it's the wider biopsychosocial model that actually also helps people keep happy, healthy and here. And so since the early 2000s, it's been very important to think not just about the physical health or the mental health of individuals, but also about their social health in order to help support them in happy, healthy work. And there is very much evidence out there. There's often a pushback to say, well, you know, isn't some of this stuff soft and fluffy and doesn't really make a difference? And as far back as 2006, Gordon Waddell and Kim Burton were commissioned by the Health and Safety Executive to do a very major review. Is work good for health and well-being? And very much they both promoted this idea of the biopsychosocial model, but also they were very clear that actually good work is good for health, bad work is not good for health. And they coined this concept of good work. And at its most basic, occupational health is about ensuring that we recognise what good work is in terms of that fit with the individual's capability. And since Waddell and Burton, there have been multiple academic reviews, major organisations, Royal College of Physicians, Royal College of Nurses, the SOM itself, and multiple expert reviews which have contributed to try and keep this policy agenda moving. And my message in this simple introduction, I'm really rather a warm-up to Karen and Janet today, is that you don't need to be a doctor to actually contribute to that occupational health agenda. Indeed, you don't actually need to be a healthcare practitioner in many cases, because as Jean said so eloquently in her introduction, actually this is about beginning a simple conversation in terms of what people need to keep them either in work or stop them falling out of work. And working with Kim Burton, I know Kim Burton may be on this call, but he also is contributing to a later one of these webinars. It was Kim that helped me understand this model of tiered intervention. And this staircase is to remind me that basically, actually, a lot of the interventions that are actually effective in managing occupational health are non-medical interventions. They're low-level interventions. And at its simplest, the first rung of the staircase is about self-management. So it's about awareness of what is okay to do and what isn't okay to do. And I guess part of that is providing good quality evidenced information to individuals that they can rely on and that they can trust, because there's an awful lot of myths out there. If I went back to the time when I was working with Royal Mail, the common myth was that if you had back pain, you shouldn't be doing a physical job. but actually our understanding has now changed in terms of back pain, that actually, yes, you might not want to be doing professional weightlifting with your back pain, although some athletes do, but actually some physical activity is good for you, and actually keeping moving certainly will ensure that your back recovery from a back condition can be improved. Jean mentioned the fit note, and the fit note was brought in instead of the sick note to try and encourage a conversation between managers and their staff in terms of what they could or they couldn't do. Unfortunately, the reality is that the time to complete fit notes well is just simply not there in modern general practice at the moment. And quite often the GP does not have the time to actually open up the conversation with their patient in terms of what they should and shouldn't be doing in terms of work. And that means that many fit notes are issued without any advice about what people can and can't do. And therefore, they turn up to their employer with a blank fit note. So a very important second step on the staircase is, regardless of what is on the fit note, it's important for managers to talk to their staff. What can I do to help support you? Are there some simple adjustments that we can actually make? Is there any help that you would suggest that we actually provide to you to help you get back into work safely and at the best possible opportunity for you? Another low-level intervention which is underutilised is using the systems. And what I mean by that is that actually awareness about how to use, for example, access to work services is relatively low. So there are many people that will benefit from very simple help from the systems that are actually out there and exist. So systems like the health and disability tool that is hosted by YouGov at the moment, which actually give very clear advice to employers and employees about how to have a healthy conversation around work, are underutilised at the end of the day. And none of these low-level interventions actually need a doctor or a nurse to actually provide them. They are, at the simplest, actually about understanding that in 2024, occupational health has changed from that managing of horrible risks in the workplace, and they still are important to actually control and prevent harm occurring. But actually, modern occupational health is actually about helping people to perform highly at the end of the day. And so my final point that I want to leave with is actually it is safe to talk about health and work. And actually, we can trust employees to actually be able to tell their managers about their needs. Many employees don't bother to do that because they don't think their manager will be receptive. And that's why a lot of the low-level interventions in occupational health are about exactly what Jean started this webinar with. It's about encouraging a healthy conversation. Thank you, Jean.
Thank you so much, Steve. That was a really brilliant overview of the landscape that we are really looking to impact in and the real change that we can make, and hopefully was helpful for attendees to kind of understand that actually there's a lot of simple steps within here that all start with sort of being in that right place and opening the door to that conversational piece about how your current employment situation might be impacting on your health or vice versa. So in the interest of ensuring that we create plenty of time for questions and for discussions, I did just want to open up the floor to attendees if you have any questions at all for Steve on the presentation that he has just shared with you, to see if we have any QA for this section before we move on to our next item, and we'll have further space for QA as well at the end of it all if it doesn't strike you immediately. But over to the floor.
I think I've put them all to sleep, Jean.
I think you've stunned them to silence.
I think you did so well, and you made it so seriously. You made it so understandable that I haven't got any questions, but maybe somebody else has. But thank you. It's very interesting.
Arthur, thank you so much for sharing that. I think that was from Lee. Thank you so much for sharing that.
You're very welcome.
And I see our first hand has gone up. So, William, I'd be delighted to bring you in. Thank you so much.
Okay, thank you very much. A question for Steve, obviously. So, Steve, there have been some attempts to sort of bring OH agendas to small businesses in the past. I can think of many such interventions. It was referenced last week by the Prime Minister. What's going to make the difference this time? Because I was listening to Jeremy Vine on BBC Radio 2, and I think the comment was, I hope it's not going to be another sort of call centre driven by algorithms. So what's going to be different this time?
So I have the privilege of sitting on the expert task and finish group that the ministers announced. And I think one of the differences now is that there's much greater understanding and awareness about this agenda and its importance. So there is, as part of the work that group are doing, there was a meeting recently with small businesses, and I was amazed at how receptive the small business organisations were. We're flipping from that position of it being a push agenda into it being much more of a pull agenda, with employers recognising that actually it's quite hard to attract and retain talent, the agenda is flipping from it actually being just simply about sickness absence. It's about employers recognising that this is part of actually what helps them be competitive in the long run. And I think the other thing that Jean and her colleagues are doing particularly well at the moment is actually understanding the communication part of this agenda needs to change. And in the past, there have been tools that have been designed but just haven't been taken up because actually employers haven't recognised that they're actually there. And this time round, I think there's a different level of communication, which is why you've got a Prime Minister standing up and talking about it for the first time.
Okay, thank you.
Thank you so much for sharing that, Steve. And I'm seeing hands starting to rise, which is fantastic. I had one small reflection just to add to that as well. I think what's also different this time is that there's a collective awareness at all levels and in all parts of the system, national, regional, and place, and amongst politicians of all different colours, that actually there is a workforce piece here that is incredibly important as an enabler to all of this, and that there is a recognition of needing to make that investment in how you bring it all together. And the second thing I think is different is that there's also a simultaneous investment, not just in enabling those low intensity conversations in communities, but also making sure that within the clinical pathways, we are also supporting and enabling a different conversation. So obviously our employment advisors in Talking Therapies programme is scaling up to national, but we're also looking at whether or not we can place employment advice alongside clinicians in musculoskeletal clinical pathways. And if we're able to do that, then actually it relieves some of that clinical pressure, but it supports them to have a conversation and have an expert alongside them. So actually, we're tackling both sides of the system simultaneously and making sure that there is that join up, which I do think is slightly different from where this might have been looked at previously. So I'm really delighted to be bringing in Kuldip next, and then Joanna. Thank you.
Thank you. Do you think there'll be enough occupational health professionals as this agenda grows and moves? Would that be a point in health assessment, in the PIPA health assessments and the WCA health assessments? We find it hard to keep and retain staff. So it's just thinking about,
I think that's
to help.
I think that's a good point to make. In the past, I was responsible for setting up one of the first national PIP assessment teams, and I can remember having many conversations with the DWP at the time about the opportunity during a WCA assessment or a PIP assessment to actually have a work and health conversation. And to be honest, back then, it was something of a deaf ear. But I think those conversations are now taking place in a different way with the various policymakers and the various parts of the policy jigsaw. So I think one of the things, and again, Jean has just said this, is there's a convergence of multiple programs that are actually getting a lot of funding and a lot of will to do things differently. And that's why we're thinking differently about fit notes, for example. So I'm finally agreeing with you.
Did you want to follow that up with anything, Coldip, before
No,
I
it was
move
just
on?
to say thank you.
Lovely. So over to yourself, Joanna, and then Matthew. Thank you.
Hi, I'm a partnership manager working across Birmingham and Solihull, covering 16 job centres. But in my previous role, I was a disability employment advisor I was proud that we were selected as a health model office back in Stourbridge, and there was half a dozen GPs I was engaging with quite regularly back. I'm talking pre-COVID, so it was a while ago now. But the feedback from the GPs is they felt that as their advocate for the patient, they'd only got 10 minutes. They felt they had to say they were unfit for work because they were worried about the impact on ticking the other box to say they were fit for work, and the subsequent impact on their universal credit. And we have a big churn of staff, and we'd have a slightly separate system in our district, I think, to maybe what we did back when I'm talking about. But I did observe some work coaches at the time, if a note was ticked as fit for work, they weren't necessarily putting them through for the work capability assessment because they were saying, oh, they're fit. So I think there needs to be an education piece with the GPs to help reassure them that if a note is ticked to say they're fit and there's certain recommendations, that we will still help them to look at whether they're entitled to extra benefits if they're trying to work. I recall a paraplegic gentleman who desperately wanted to work, and people with autism didn't want to actually go and get a fit note because that's not a sickness as such. It's a lifelong condition. And so it's nice to see Karen Orman, actually, because I did actually talk to her back, she probably doesn't remember, but a long time ago. So this is all very much.
I recognise
you. Do you remember? Yeah. So we had a meeting. So this is everything that I was trying to achieve back in that former role, but that there is a big education piece there with the doctors. So just be interested to know what we're doing around that.
And I think that will link very nicely into the work that Janet's going to talk about in terms of actually both broadening the number of professionals that can engage and provide help and support. And Karen also will talk to that in terms of thinking differently about actually it just being the GP that engages in these conversations. And certainly we are doing a lot to get it into basic medical student curricula, and also in terms of widening exposure of all types of doctor to understand the occupational health aspects of actually the treatment that they're providing. And part of the major conditions strategy and the framework that was announced on the back of that is to look at how we can integrate these conversations into mainstream healthcare more widely and not just restrict them to happen in that 30 seconds or so in a general practice consultation. I'm going to stop there, Jean, because I'm conscious of your time, and we can discuss this more widely in the open conversation afterwards, can't we?
Absolutely. So I'm going to bring in Matthew, and then as we don't have any hands, I'm then going to move us on to our next expert presenter following that. Over to you, Matthew.
Thank you. Please don't confuse me with an expert. I just wanted to build on that point about the bottleneck and how what we do where we struggle. How can we quickly boost the occupational health assessment capacity in a place? Anecdotally, I've got GPs telling me that they're having to write fit notes because patients can't get occupational health assessments to allow them back to work. And I just wondered what, if any, consideration has been given to employer side interventions to encourage employers to soften their requirements for occupational health assessments to let it, if a patient wants to go back to work, if their symptoms have alleviated to the extent that the GP can say so, but there is no available resource in the occupational health assessment to complete the full Monty, so to speak. Is there any thought being given? And perhaps this just cues up the next bit of conversation this afternoon, but that was my question. Thank you.
And I guess, Jean, that's very much what the framework that the expert task and finish group are really trying to achieve in terms of actually building those tiered approaches that involve employers and employees in the first instance, having the resources to be able to have those conversations in the first instance, supported by an adequate onward referral, if necessary, to healthcare professionals.
No, you're exactly right, Steve. And I think it's a really important element that you've touched on there, Matthew, and a lot of the work that we're doing in our business facing, particularly smaller business facing occupational health reform agenda. So we have the workforce element, and then we have actually the employer facing element, the investment in models of occupational health for SMEs specifically. They're 5 times less likely than larger employers to have any access, and the market isn't necessarily geared up to meet those more one-off purchasing needs. So we've, I think, 2.5 million. We're investing in innovation over the last 2 years. Our work looking at whether or not supporting market navigation and incentivizing to make it a bit more affordable can help, because we know cost and awareness are 2 really big barriers for employers. But I think this is also one of those areas where employers can come together with the health system to come around a patient and get the best outcomes for both the business benefits for the employer and the health benefits, particularly upstream on the prevention agenda for the health system. Because actually, if the conversation about the note when the person is first unwell, if they go with maybe fit, but even if they give them a few indications of what an employer could do, often that can be enough. It's like, can you give them a flexible pattern or a bit of a phased return? They might need to take some more regular breaks. Actually, that often can be all an employer needs to go, oh, okay, I can do those. I know what to do. I can do those things. And I think that segues incredibly nicely into the amazing roles that occupational therapists, vocational rehabilitation can offer. So I'm not going to say any more, and I'm going to hand over to Karen, who is our next presenter. Thank you.
Thank you, Jean, and hello everyone. I'm just going to have that awkward moment as I share my screen. And I hope that's come through for everybody. Yeah, that's great. Thank you. Thanks for the confirmation. Okay, I can relax now. So I'm going to introduce you to occupational therapy and vocational rehabilitation. But at the risk of repeating some of what Steve has said, perhaps just sort of reinforcing some of his messages, I just wanted to start, as much of our current sort of public discourse is primarily centred on the economically inactive and the impact on UK productivity. But I do think it's worth highlighting what work can do for us as individuals. It can be a route out of poverty. It offers financial security, supports our sense of self-worth, can provide purpose, routine, a sense of achievement, shapes our identity. You know, often our first question to someone new is, what do you do? And also our sense of belonging and social contact. So I think we need to hold that in mind when we think about going to work and working. So why is work so important now? I'm not going to sort of go over everything that's just been outlined by Steve and Jean, but we do need to change our approach to be more proactive in managing our health. We're living for longer, but with more complex health conditions, and poor mental health, particularly in our young people, is rocketing. So there's a lot of information and advice out there, but we need to improve access to the right advice at the right time to support people living with health conditions to carry on contributing to society and staying in work. And good work can be part of our public health delivery. And occupational therapy has a role to play in achieving this. Occupational therapy is a science-based regulated profession, and within a BSc or MSc programme, we cover not only the body, physical health, but the brain too, looking at mental health and psychology as well as society and culture. Everything's viewed under the lens of occupation. Occupation not only covers the term work, but it's a term for all the activities that we need and must and want to do. So in relation to work, occupational therapists can assess a person's physical and psychological well-being to find solutions, analyse job demands, and match abilities to tasks, all the way through to advising on career redirection if their current role is no longer workable for them. So how is occupational therapy different to an occupational health nurse, for instance? Well, we work within models such as the PEO model. So looking at the person, their health, family circumstances, beliefs, mindsets, their occupations, and then also the environment, whether the environment supports or hinders what the person needs to do. And these three elements determine the complexity of need and the level of intervention required. And in terms of assessing a person's ability to work, we're looking at the person's health, work tasks and patterns, and other occupations that may impact on the work that they do. So they may have roles and responsibilities, such as being a parent, for example, of young children, or looking after frail older parents, and that's going to impact on their ability to do their job. And then, of course, we assess the workspace, and we can then work with the individual to improve their resilience, teach strategies and techniques, and make adjustments to the environment to support their performance. Steve spoke about tiered interventions, and I'm going to touch on tiered delivery. Universal, so that's what we can offer most people, targeted, and then specialist delivery. So where are OTs working and what are we doing? Occupational therapists are now starting to work in primary care across GP surgeries, where they can complete the fit note and give advice. And unlike GPs, we aren't tied to a 10-minute window. So typically we will meet with somebody for 45 minutes to get a full and rounded picture and to be able to give that advice there and then about how that person might continue in work as a phased return or with some reasonable adjustments. We also work with social prescribers within GP surgeries and other local resources such as charities to ensure the person gets support, exercise, advice to help with their overall well-being and other aspects of life like managing their finances or housing. Prior to the pandemic, occupational therapists were running programmes in NHS services, training all staff to feel confident to ask patients of working age about work and signposting for advice and services if they needed it. With the pressures on NHS services, this is something that has been mostly discontinued, but the expertise is still there and could be revived. So at any point of contact with the NHS or social care, you should be asked if you're working, what type of work, and directed to the appropriate information and support. Occupational therapists are embedded in the NHS and social services, so we work in mental health and general hospitals, a range of community services, and all occupational therapists can support patients to manage their health condition and symptoms, such as pain, anxiety, fatigue, depression, to work towards being able to work. The challenge with being embedded in secondary services is that we see patients when they're acutely unwell or have reached crisis point or have been struggling for a long time, and the person at that point is not ready to consider being in work. This is why we're fully in support of increasing community rehabilitation services, so we can work with people once they've received a diagnosis, had their surgery or medical intervention, to get them back on their feet and living their lives fully. And then at a specialist level, we work in occupational health and vocational rehabilitation. Vocational rehabilitation is an idea and an approach as much as an intervention or a service, and can be delivered in a range of settings, from student support services in universities to workplaces, through DWP contracts and through legal and insurance firms. So I've introduced occupational therapy, where we work, what we can do, and introduced the concept of vocational rehabilitation. but let me make this a bit more meaningful for you with a case study. So we have a 23-year-old young man who attended university through 2019, 2020. At the height of the pandemic, he had to leave to return home and study remotely, and then experienced low mood and depression, but he didn't seek medical advice at the time. In September 22, though, he's graduated, he started his first job, a role in an office, and initially managed well, but then became depressed. He was signed off sick and officially diagnosed with depression by his GP. Through occupational health, he was offered a worksite assessment by an occupational therapist. She discussed in depth the occupational demands of the work and what he found most challenging, so she could make suggestions around reasonable adjustment. The company offered hybrid working option, and they agreed to this and to flexible start and finish times as long as his duties were met. Over 4 sessions delivered remotely, the OT gave advice to manage a balanced routine, offered emotional support and a space to discuss progress, identified with the young man any further obstacles, but also focused on what was working and why. The OT intervention cost £1,600, but the employee remains in work and has actually had a promotion. And then just to give an illustration of vocational rehabilitation. This is an example from a specialist service at the University Hospitals of Derby and Burton NHS Trust. They accept referrals from GPs and other healthcare professionals, as well as occupational health referrals, self-referrals and management referrals for staff working within the organisation, so within the NHS Trust. But they also have private provision, primarily for Rolls-Royce, but also some local small to medium-sized businesses. The occupational therapists assess and treat a variety of musculoskeletal conditions that are limiting a person's functional ability. The team complete fit notes and assess fitness for work, providing the employers with comprehensive reports on people's capacity to work. People can practice work-related activities such as lifting, pushing and pulling, and many people will be treated within a group. So indeed, they typically work with 60 patients a day. Post-discharge at 12 weeks, 97% of people have returned to work, with 78% of those completing full-time hours and duties. So to sum up, we've got occupational therapists already working within NHS social services and as private providers, supporting people to be in work, but we need to move more of this expertise into primary care and occupational health so we can give that advice earlier. We need to also make sure that work coaches and others giving employment support can access advice from occupational therapists on addressing the obstacles to work, such as fluctuating symptoms, housing, transport, etc. Our focus also needs to be on what a person can do, considering their capabilities and situation, rather than a one-size-fits-all condition approach. And I'll stop sharing there.
Thank you so much, Karen. That was incredibly helpful and hugely rich, as well as really kind of bringing it to life, which I always find an incredibly helpful way of understanding the complexity of this landscape, actually being able to sort of have that example of how someone's gone through that lived experience and the difference it can make. So as with previously, I'd love to just open the floor up and hear from people on the call if they've got any questions at all for Karen. And I know there's some things that have been popped down in the chat as well, so I'll try to pick some of those up too. But Maureen, your hand is up. Please do come in. Thank you.
Hi, that was a really interesting presentation. I was just thinking about the new occupational health vouchers that are being trialled in parts of England, where employers can get up to 80% of the occupational health assessment funded. It's around about 400, they expect between £400 and £600, I think. So the cost of this is £1,600. How do you see that kind of linking in? Would it be linking in with primary care, or that private occupational health practitioner can then tie in with that?
Oh, Maureen, that's a good question. I see the primary care, the offer within primary care, as being separate to occupational health, but feeding in and more having that tighter conversation. So I think, you know, we had an illustration, I think it was from Joanne before, about you know, work coaches, for instance, not being able to somebody being signed okay to work, but not feeling that they can put that individual forward. What we're seeing with occupational therapists working in primary care is they've got more time than the GP, so they can have those conversations and do that linking up. So the occupational therapists in primary care can then talk to counterparts in occupational health and do that linking up. So I see that as, you know, the primary care offer is about OTs being part of the statutory services, and then with the occupational health offer is more of a mixed economy. So you'll have independent providers and providers working based within occupational health services. The challenge I have with this topic is occupational therapy and occupational health is very easy to trip over together.
Mm-hmm. Thank you.
Thank you so much for that, Karen. And it's just worth saying, Maureen, if assuming you're referring to the pilot in the Northwest, which is the one that my team is leading on, we see it as absolutely interlinked, which is why I have both the workforce activity and the work to invest in sort of addressing some of those barriers all in one place, as it were. And I think the key is that with this, there's three elements you need to make sure are right. The first is that you need to make sure there are providers out there offering services that are able to sort of come to the table and say, yes, we want to be part of this. You've got to have employers who know they have a need and are kind of intelligent customers knowing this is what I think I need, and then needing to purchase it, and then sort of wanting to kind of come on board with it, and then being able to get that experience that sort of Karen set out of the real impact it can have and the benefits it can offer. And ideally, when that all comes together, then what you get is that continuous engagement with what occupational therapy offers, with what vocational rehab offers on a long-term ongoing basis. And often employers talk to other employers, businesses talk to businesses. So it's actually like, I use this thing and it made a real difference to me. So it's an opportunity to bring the two, bringing the two together to get almost that first bite of the cherry of, look what this difference this can make for you, with the hope that actually that then leads to that longer term engagement and continued sort of partnership between employers and occupational therapy, vocational rehab, and really seeing them sort of joined up. That's the aspiration of where we're looking to go. But I think, as other colleagues talked about, a lot of this is a journey and it's culture change, and it doesn't happen overnight, but it's about taking every opportunity to help support making those connections and the impact it can hopefully have. But it's a really great, very apt question. So thank you. We have another hand. So Jenny, can I bring you in now, please? Thank you so much.
Hi, just wanted to ask a question just about people that are working in those companies which don't have any access to occupational health at all. And I know there's many industries that don't, and small businesses that just don't have any access. And are these people going to be able to use the service working within the primary care, even if they don't have the links to occupational health? They'll only have the occupational therapist within primary care, or are they going to be able to get half a service or a full service, or how is it going to work for those people that don't have that extra backup?
Jean, perhaps I can just intervene there. I think one initiative which is working very well is for some of the larger employers to actually provide advice to their supply chains, and that actually helps to widen access to occupational health even from quite small businesses in the supply chain. So Jaguar Land Rover is a very good example of that.
I was just thinking we could do a call maybe to plan this weekend, or not this weekend, the weekend.
Oh, I think somebody else is. I was just going to come in. I think because we're starting to see occupational therapy rolled out in primary care, we're seeing variation across the UK about what the services are offering. However, we have piloted occupational therapy vocational clinics in England and in Wales. And so people either self-referred or were directed by their GP, the practice nurse, or indeed reception staff to the occupational therapist. They would get their assessment, and sometimes then it was a one-off piece of advice to support that person to go back to work. Sometimes it was up to 4 sessions, which could either be done in person or remotely. And with the patient's permission, we will sometimes then, the occupational therapist would sometimes be talking to the employers and just being that conduit to help with it. So it is an offer that you get, an enhanced offer that you would get through the primary care service, and wouldn't necessarily be dependent on an occupational health team or service within your organisation.
Brilliant, thank you.
Thank you so much for that really helpful question there, Jenny, and that really helpful response as well, Karen. And I can see someone has popped it in the chat as well. But I think the challenge that you're describing there is very much one of the reasons that there is this investment happening with WorkWell. It is designed to offer some of that lower intensity biopsychosocial, less clinically heavy sort of intervention and support, and in particular identify where someone may need that more complex support to then be able to get them sort of across to the services that kind of Karen is describing. But not everyone will necessarily need that intensity and level of support. And colleagues, please do quote me if I'm wrong, but at one of the previous meetings we had, I think the number that you gave was between 3 to 7% of all of the cases are the ones that often need the high end, really complex sort of clinical support, but actually the vast majority are not necessarily in that space. And so, Jenny, what we really do hope with WorkWell is that it will be able to start to operate in a bit of that gap for those who don't necessarily kind of have anything and don't potentially need something more intense. But excitingly, it also offers somewhere to start that conversation where they do need something more intense, both into the primary care NHS, but also back to employers. Did you know that actually, so these are the things that you could do, but also you should think about getting some OH. This is how it can be preventative and help you. And here are the different ways where here's the framework you can have a look at about the things that you can do. So it's also about making sure the support goes out both ways as well to help. And thank you so much for that, Anna. Really, really helpful. Thank you. Brilliant. So I'm going to bring in Lee, and then I'm going to move us on to our next esteemed speaker after that. So over to yourself, Lee.
Hi, thank you so much. I just want to sort of be clear. Where does the money come from? So is it from the employer that say it's going to be the 1,600? Does that come from the employer? If I'm just not sure on that side of it. If you could just confirm it for me, please.
Of course. Sorry.
Sorry, can I just say that that's just one example, and that employer paid that an independent occupational therapist to give that to deliver that service, but that's just one example of a case study. That's not an example of this is what the cost would be, carte blanche. Yeah.
So but there is a cost at the end of the day. I just need to get it clear in my head. So at the end of the day, it may not be 1,600, but there will be a cost to the OT. Is that am I understanding right?
If you are going through and employing an occupational therapist to deliver as an independent provider, there will be a cost. Right. However, we support people to return to work and remain in work through NHS statutory services, charitable services, and increasingly now primary care. So some of the work that we're doing, particularly around vocational rehab, is NHS delivery. Isn't occupational health.
Right, thank you. Sorry, I just needed to get it straight in my head.
No, that's I'm in it all the time. It's really clear in my mind. It's not clear to anybody else if you're not in it.
Yeah, thank you so much.
Thank you so much, Lee. So it's been a great conversation so far, and we've still got one more presentation to go. So I'm absolutely delighted to hand over to Janet O'Neill from National School of Occupational Health, who's going to talk to you some more about the different roles in a multidisciplinary team and how you can build and how you can focus on building that capability. Over to you, Janet.
And thank you very much, everybody. I've certainly thoroughly enjoyed what been hearing today, and hopefully everybody will find what I'm going to speak about equally as interesting. So hopefully you can now see my slides. Okay, brilliant. I'm just going to move on because you all know that I'm Janet O'Neill and what I'm talking about. So what I'm going to focus on really is the why, what, who, when, and that multidisciplinary response that needs to address an individual's barriers and support their needs. And I know that the terminology is changing away from barriers recently to more obstacles, because it's easier to move an obstacle than it is to remove a barrier. But I just wanted to first of all go back to what Steve was talking about earlier about that biopsychosocial model of health, and certainly it was really interesting to see Karen's slides, because actually there's quite a crossover there, and I'm going to link into that in a little while. But you can see that actually the person's makeup, only part of that is sort of biological, the social, psychological, and cultural relationships, coping skills, everything comes together to create that one very individual person with all the different parts. And it is why when we see an individual with back pain who's coping really well in work, and somebody with exactly the same back pain and similar type of role isn't coping in work. In fact, I'm going to just digress here and go to a case study that I learned from Steve Bowman a few years ago, when he spoke about a postwoman who had had surgery, gynecological surgery, that he had seen 4 weeks after her surgery. Same surgeon, same day, same surgery. She had already discussed with her manager what she was going to do, how she was going to do it, and when she was going to do it. And then he saw someone else who had exactly the same situation, but different working environment, and 10 years later she still hadn't returned to work. And that's always really stuck with me, that people are really individual, and the workplace makes a big difference, which is why we in occupational health look at the psychosocial flags as well. And the psychosocial flags is where you bring in those occupational factors alongside, what's happening organically, medical problems that can affect people, their medication, and alongside actually what do they believe, what are their coping strategies, whether there's some other distress, whether they have illness behaviors, and are they willing to change, with that support from occupational health. And don't worry, I will bring this into the multidisciplinary team. But then you've got your occupational health, occupational blue flags, that sort of work status, health benefits, insurance, and your work satisfaction, working conditions, work characteristics, and social policies. And these psychosocial flags really sort of generated from a musculoskeletal standpoint, and they have been incredibly useful in occupational health for us to identify what those obstacles are for those person, being red flags are the health, but then the yellow flags the person, blue flags the workplace, and black flags being the context. Now, all players have a role in spotting flags related to these three issues, and the key is to start looking as early as possible, or to start addressing factors as early as possible. I'm just going to move my slide on here. So what are the influences on health at work? So identifying the occupational health workforce, and within the influences on health, we want that good work is good for health. So if we think about those blue and black flags, we can't just focus on the individual. We've got to actually focus on where that individual is within that workplace. So what can be done to reduce the risk of people becoming too ill to work, and that role of the multidisciplinary team. And so therefore understanding the influences on an individual's health at work in the workplace, that workplace culture, and I think Steve mentioned the psychological contract with that individual, how safe that person feels at work. And that incorporates the ethos of the organization relating to health, policies, procedures, ways of working, all which contribute to that supportive culture. There are a lot of tools out there for managers and organizations to be able to use. So the HSC management standards, NICE guidance, CIPD, lots of reputable organizations have good guidance on the topic, but not all organizations are actually confident in using them effectively. The WHO, or workforce supporting the workplace health, depends on these factors, plus, of course, the social determinants of health. Health advice and education in the workplace obviously focused on health issues that are common in general society. And I think Jean mentioned cardiovascular issues as being one, but obesity, smoking, diabetes. So what are the societal and lifestyle programs? And organizations can use sort of national data profiles or tools to understand the health needs of that organization. And of course, that might need specialist input, specialist understanding of work. Then, of course, there's the work environment, the ergonomics, the heat, the cold, the dust, the noise, the vibration, the relationships between colleagues, the work pressure. Communication is a big one, and of course, learning and development. How can people feel as if they're growing and developing and safe in that workplace? And there's a lot of focus within organizations around ESG, environment, social and governance, and social value, and identifying those needs and which can contribute to a reduction in the risks to health caused or exacerbated by work. So it's not just looking at the individual, but it's also looking at that work environment. And of course, the role and tasks are an influence, as there may be related risks, but also whether the role is not conducive to that person's health. So Steve mentioned earlier that just because a person it has got a health condition, it needs to actually be matched, and what sort of adjustments and support could be right for that individual. So, for example, an electrician who has a shoulder injury, and that actually precludes them from reaching above shoulder height when their job is reaching above shoulder height. So facilities in an organization that enable early access to support, so that psychological or physiotherapy support, rehabilitation, as we've just been talking about, and that individual health advice. And also identifying adjustments within those organizations which will support those needing temporary or permanent change to help them return or remain in work. And I worked with an organization that I thought was absolutely fantastic, because they had already mapped the adjustments, and this is without occupational health support. They had already mapped those adjustments that they could reasonably tolerate within the workplace, and for how long they could tolerate them before they needed to open up a space for someone else. That sort of proactive way can really support people coming into work, and doesn't always need that occupational health advice. And one thing that, we've been talking about SMEs, and actually the Federation of Small Businesses have reported that 51% of SMEs do already support disabled people in work. And if you consider the number of SMEs that don't have occupational health, a lot of them are doing this without us per se. And of course, that can be as simple as using those resources available that I've been talking about. But obviously the occupational health MST, multidisciplinary team, can influence and support employers and actually provide that individual support if they don't have the confidence to do that. because none of this support within the workplace or understanding the workplace is possible without the linchpin of the line manager. And once again, Steve did mention the important role of the line manager. They are the most significant person in an employee's life and can actually make the difference between staying in work or leaving. Having that initial courageous conversation and open conversation, and plus enabling those onward referrals, signposting, can actually make that a massive impact on that person's ability to be in work. It's not always a natural position, though, for many line managers, and they need a lot of education and support, but also a toolbox of free support and guidance. And I would say that, just going back to what Karen was talking about, understanding what's in their local environment, what is available through primary care that people can ask for. So that brings me to the multidisciplinary team itself, who support organizations, employees, and of course, those very important line managers. And you'll see that I've got a massive number of professions part of the multidisciplinary team. And believe you me, this is in all of them. So actually, it is a massive team. And I have to say, our awareness of the multidisciplinary team is growing and growing, and which is so reassuring for us to be able to understand what support people need. So the who is as wide as is needed. So the workplace brings together all health conditions. In occupational health, you become so knowledgeable. Well, this is why I find occupational health so fascinating, is the number of different conditions, but also those psychological factors, and in very different environments. So supporting people to maximize their health at work and reduce the risk of work on health actually takes it takes strategic thinking and planning, which obviously is really possible within an organization without that occupational health support. And as Steve mentioned, maybe a low intensity and a non-clinical focus is actually all that's needed, as we've talked about with the line managers, but with good education on that good quality work and good conversations, and a toolkit, if you will. But also understand their limitations, and to go out to the workplace experts or have access to that workplace health support when needed. But I think the reason that we have so many different parties within the multidisciplinary team is because we need to bespoke to the actual needs of that organization, the needs of the people within that organization, and of course the needs of the local environment, the wider environment, what's happening not just here in this bubble, but actually what's happening outside of that. And we were really, National School, really fortunate to work with the Joint Work and Health Directorate, obviously with many really important stakeholders on a task and finish group. And we were able to identify elements in there around the multidisciplinary team. But alongside that was the growing NHS occupational health and well-being scheme. And one of the things they did was actually fund a workforce study, and that was the London Centre of Research, which scoped and assessed the multidisciplinary clinical workforce. And that was just within the NHS. But obviously, I also work outside of the NHS, so I know the vast number of clinical professionals and non-clinical professionals that are part of our occupational health team. But this was absolutely fascinating work, and they found a real variation in job roles and background in both that clinical and non-clinical. And of course, this marries with the November 23 Occupational Health Working Better consultation outcome, which puts that real biopsychosocial focus on the multidisciplinary workforce, which we've already discussed. And that could be the work coaches that we've mentioned. And we know that some spearheaded the trial, which has shown some good success. We know that social prescribers, there's emerging evidence about social prescribers, which Karen talked about, occupational therapists linking in with social prescribers. But what the research study from the London Centre found, that actually some OH departments already employed social prescribers within that department, and actually social prescribers sit really well in occupational health and understanding, what does that organization offer that people can tap into, but also then what is outside in the community that people can tap into to help them manage that first step that Steve was talking about, to help them in learning how to manage their own health, but also in those GP surgeries. And the strategic overview for organizations, for them to understand all of these elements that are so important in marrying people to the organization, is usually spearheaded by occupational health doctors or nurses qualified in occupational health, and experienced and competent in occupational health. But more and more, we're actually noticing instances of occupational health OTs and occupational physiotherapists start managing occupational health services, and that includes both in the private sector and in the NHS. And that strategy, I think, is exceptionally important for especially in collating the data, if you like, for organizations to get that understanding of what they need for their people. But also that actually, when you listen to what Karen's saying, there's a lot of cross-pollination between occupational health, occupational therapy, physiotherapy. So it becomes that interdisciplinary as opposed to a multidisciplinary. We can all learn from each other. And Steve was relating a few days ago on how when they introduced occupational therapists into the Royal Mail, that actually the current clinical workforce, the occupational health nurses and doctors, learned so much from them. And this is where bringing in all of this multidisciplinary team can actually elevate occupational health so significantly, with the learning that we can have from each other, as well as the specialisms from each other. Now, mental health and musculoskeletal health are, of course, a large part of the health issues noted in the workplace, as are chronic health conditions. And these days, we often see those sort of multifactorial health issues. So having early access to treatment and assessment for mental health and musculoskeletal health can be exceptionally useful within organizations, and they play the physios and our psychologists, counselors, psychotherapists can have a massive impact. In fact, we were at the Houses of Parliament. I'll just shout out, thank you very much to Sam for organising that, talking to the Occupational Health and Wellbeing team, and how the huge part that was played by the occupational psychiatrist and the occupational psychotherapist, and a massive amount of work that they did in that department. And actually, something fairly new is they have a workplace adjustment support manager that actually works within the occupational health team, supporting those that need equipment and need specific workplace adjustments. So I think there's still a lot of scope to move. There's been quite a lot of research, and certainly in that recent Growing NHS report, case managers are particularly useful in identifying different needs that people have. So whether they need to go to an occupational therapist or a physiotherapist or an occupational health nurse to look at the risks, etc. So lots of really great support that may not actually be clinical. But we mustn't, of course, forget our hygienists, technicians, nurses and physicians that support the reduction of risk that these people need to come back into work to, or not fall out of work because of the risk of health at work. And then on top of that, we've talked about education, health education. The workforce is a fantastic place to provide that education. And there's been some good researched evidence that providing health promotion and health education in the workforce, and certainly I work with physiologists and sports therapists and nutritionists, and that was also borne out in that research piece, that those elements of occupational health are incredibly valuable in supporting the effects of health on work. So I'm nearly finished, you'll be pleased to say. Let me just move this slide on. So let's go to capability. And I mentioned that we were very fortunate and still are fortunate to work with the Joint Work and Health Directorate with the task and finish group. And certainly we identified that training and education is essential. So that training program, you know, the funding of training, we expected around about 100, and we had over 220, I think, people, as G mentioned, sign up that have gone through the training. Some are still going through training, some are now going through their exams. So that's been exhilarating. And just as an anecdote, I was at the Health and Wellbeing Conference, and this lady came over and she gave me this most enormous hug and said, "I'm Saoirse, you've helped to fund my exams." It was just such a wonderful experience. So it has made an enormous difference to people. Obviously, that's a proof of concept. So therefore, we will be having a look to see what the impact has been on the occupational health workforce. Because, of course, it's fantastic to have a workforce, but we need enough of the workforce, especially with everything that's been discussed today. And I think it's going to be that focus on the multidisciplinary team, focus on that interdisciplinary team that's going to really support that growth. And certainly there's the potential for the funding scheme, if it goes ahead, to increase the next allied health professionals. But it's all looking really a positive as well. But as Norrie et al. In their recent study that was published just a couple of months ago on occupational health awareness and understanding, certainly there is definitely areas where we can increase awareness. And so, you know, a good year ago, we started looking and focusing on placements, undergraduate placements, because as Norrie et al. Mentioned, we need to capture that workforce younger. We need to capture them actually earlier in their career, where pay is not such a big issue when they transition over. So and this is definitely gaining momentum. We've got a podcast coming out soon from SOM on placements, undergraduate placements within occupational health, the awareness that it raises. But it doesn't just raise awareness for those people to come into occupational health, but just going back to what everybody else has been talking about, raising awareness generally. We need to raise that awareness for the primary care, for secondary care, that work is a health outcome. And this is one way of increasing that knowledge and awareness. Or you have to forgive me if supervision hasn't quite fitted in there. But we also need to help support occupational health departments to supervise new people that are coming in, because new people that are coming in, it's a lot to learn in occupational health. Anybody who's come into occupational health, and you just have to look at the biopsychosocial model, there's lots of different aspects, and that supervision is essential. So that's something that we're working on now. And then, of course, there's something that I feel quite strongly about is mapping. As you've seen, so many different parts of that multidisciplinary team, we need to understand where they all fit, where everybody crosses over, and make it easier for employers to understand what would be the best fit for them, you know, once they've gone through those low-level interventions and they need to come into a more specialist support. And there's certainly been a move towards it already with you know, Hilly Winch and her team at the Health at Work Network starting to build in job descriptions for that multidisciplinary team, so people understand what jobs people can come into. And then last but not least, with the awareness piece, is we just launched on Friday a mentoring scheme. And this is a mentoring scheme for those that are considering a role within occupational health. It is for the multidisciplinary team, so it's not just focused on nurses and doctors. We have already had about 34 mentors sign up. These are voluntary mentors who are keen to give back and to support and give people that are coming into an occupational health an understanding of what it's all about, because we've seen many times people just go, I just don't understand what occupational health is, and this is the clinical workforce, so how do you expect the other workforce to understand it? And I have, really pleased to say we've had over 110 mentees signed up already, and we only launched on Friday. So so if anybody's listening that would like to be a mentor, please, hopefully Nick will pop in the chat the link to the mentoring scheme. So I think I'd just like to finish in saying, actually, over the last couple of years, we've come quite a long way in building capability with all of the different interventions, including, as Karen said, that that support within primary care. And I just want to go back and give a nod to the lady that talked about the disability employment advisors, because I used to work in the Birmingham area, and we, as an occupational health nurse, and really relied on the disability employment advisors. They did an absolutely amazing job in supporting people coming back into work. So they're a really good resource without coming into OH in the first place. So I think that's everything from me. That's my whistle-stop tour. But still, of course, we still got some way to go to building that capability, but we are working on it.
Thank you so much, Janet. So it was a really full, really detailed conversation and sort of presentation. A huge thank you. So we are pressed for time. We've actually only got a few minutes left until we conclude. So can I open the floor to kind of any particular hands for people who would like to come in and share reflections? And then I'd like to invite Lamray to say a few words as well. And then I'm going to want to draw us to a close. So Tony, lovely to see you. Over to yourself.
Hi, yes, so thank you for that, highlighting the importance of the multidisciplinary team to manage a multifactorial problem. I think following the principles of person-centered care and shared decision-making, in that diagram, you also need to include the employee and probably also have a line manager, because I think they are central to actually coming up with the solution. And my second point is, it's recognized line managers are very important, but how do we support them? How do we change their focus on, looking after their fellow employees rather than just focusing on productivity? And I've come across some models, for example, having health and well-being coaches within the workplace. But how do we actually really, at the policy level or the practical level, how do we get line managers more engaged in recognizing the importance of maintaining people's health?
Thank you so much, Tony.
I guess, Tony, you've heard me talk to this before, but actually it's about getting line managers to recognise that actually this is about them supporting them in doing their job as line managers and delivering their targets. And in Royal Mail, there was a huge difference in terms of line management support to employees when they realised that actually it made a difference to delivering their service targets and them getting their bonuses.
Exactly, but I'm sure Royal Mail were ahead of the game there. And how do we get everyone else following that principle?
I do think it goes back to that sort of strategic and advice and support, which is, I think, what we're moving towards for SMEs, because that would include supporting the line managers. There's no point in just saying it's the line manager's role. Actually, we need to support those line managers to be able to do it. And that takes a whole organization to do that. It isn't just the poor old line manager. There's actually quite a few frameworks out there at the moment, and one recently that I thought was particularly good. The name escapes me, but that was published back in November. I can find it if anybody's interested, which is a wellbeing framework for line managers on how to support their employees. And I think there is certainly a focus moving towards that. So, but yeah, I personally absolutely agree. If you don't involve the line manager, you're not going to actually get any traction with supporting a person coming back to work.
Thank you so much, both. I'd really like to hand over to Lanre just to say a few words, and I know some people will have a hard stop at past, so may need to step off, but just over to Lanre, and then I'm going to draw us to a close. Thank you. Oh, you're on mute, Lanre.
Very briefly, thank you to all the speakers, and thank you to the joint unit. I think it's been an exciting and very insightful afternoon with such a wide range of insights into this issue. At the risk of prolonging things just slightly more, I wonder if each one of the speaker would mind telling us one key message that you would want to give to the people involved with Work Well, with regards to, one, increasing the engagement with it, and two, ensuring high quality of their service. So engagement, high engagement and high service. Just one or two sentences, please.
If I start, Lanre, I think the key message that I would give is to encourage people to trust their line manager and talk to their line manager about their simple needs in terms of work and health. And they should do that before they get sick too.
Thanks, Steve.
I'm going to follow on from Steve and just say, I think as well, it is a lot of people have strategies in place. So often it's about understanding what they already do to manage their health in the workplace, and then trying to amplify that, think of ways to ensure that they continue to work depending on fluctuating symptoms and the demands of work.
Thanks, Karen. Janet?
And mine is actually education and training. I think that's absolutely key for the multidisciplinary team and for the line managers out there, and for primary care, secondary care. We need to get that message across quite firmly about work being a health outcome. And we really need to upskill the multidisciplinary team as a whole, if you like, in order to be able to give the best quality. And I think we're moving towards that, but that interdisciplinary learning, I think, is going to be essential.
Thank you, everyone, again, and final words to you, Jean.
Thank you so much. So thank you, everyone, as Lanre says, for taking the time to attend. There are 2 more of these sessions, and each session is looking to take a slightly different lens, because ultimately making sure that we are fundamentally joining up work and health requires us to ensure that professionals, both clinical and non-clinical, feel empowered and enabled to have a joined up work and health conversation, that our systems feel able to come together and to join up across their different settings to really get around an individual and make sure there's that patient-centered care, but also a proper pathway between health and the support that's offered, employment and the support that's offered, and where somebody needs that more intensive support from the state, that is also in place to guide them. And we also need to make sure that everyone on this call feels that they have the tools and the networks that they need to be able to succeed. So we have got 2 more sessions. I would really encourage you all to join them. And my one tip would be really thinking about who you could involve in the conversation in your local area and within your own network. So if you're in health, do you know where your local job centre is and the relationship managers there? If you're a work coach or you're working with people and it's non-clinical, do you have a route into your clinical setting? And do you know where your OT or your VR service is? And do raise that with the relationship managers, with the Work Well team, with others, because we want to make those connections and support this really important agenda so that we get the good health and the good employment outcomes that mean so much to people and their families and our communities. So thank you, everyone. Hope to see many of you at the next 2 sessions, and I hope you have a great rest of your day. Thank you, speakers, and thank you all for coming.